Good morning. Good morning. Hi, everyone. I see that we are joining from Instagram and TikTok. Good evening. Good morning. That's right. It's not good morning for everybody. Welcome to everyone who's joining us today for our webinar, specifically about thyroid dysfunction. So for those of you who don't know me, my name is Hiva Kolodrubetz. I am the Director of Advanced Practice here at Archer. I'm a family nurse practitioner with more than a decade of experience as a nurse practitioner in primary care as well as endocrinology. And I'm really excited to be giving this talk to you guys today. We're going to get started at the top of the hour, but I wanted to sign on early and say hi and see where everyone's joining from. So hi, Ravi from India. Hi, Samran from California. I also saw someone from London, Carrie from London, and Dominique from Nigeria. Very cool. So yeah, I'm here in Texas in the Dallas-Fort Worth area. So for me, it's still morning time. It's almost 11 a.m. morning time. Hi, NCLEX buddy from India as well. That's great. From Jamaica, Rochelle. So before we get started, I love that everyone's telling me where they're joining from, which is awesome. Tell me where you are in your nursing journey. So, are you just getting started? Are you in that pre-nursing phase? Are you in nursing school? Are you going on to do your advanced practice training? I'd love to hear from you guys where you are in your nursing journey. So, Patel from Chicago, very nice to see everyone from Nepal, Somalia, Canada, UAE, United Emirates. That's very cool. And Preeti from Canada, from the Philippines, from Brazil, from Boston. Awesome, awesome, awesome. Very cool, you guys. Ruthie from Mississippi, Shelby, Mississippi. Welcome, Ruthie. Great to see you again. And let's see. So for those of you who know, we like to be really interactive and engaging in our webinars here at Archer. So I love that you guys already have your chat boxes open. I want you to say hi, introduce yourselves, get to know other people on the webinar today. That is our community, right? And the other thing I was going to mention is 10 years in telemedicine as an RN, Karina. Wow, that's impressive. I love tele. That cardiology is also, I have a background in cardiology as both a nurse and a nurse practitioner. So I love cardiac as well. Cardiac touches all specialties, primary care, everything. So really great experience to have. And then we see some students preparing for NCLEX. All right. So we're almost at the top of the hour, and I see some people are slowly joining us through Zoom as well. What I will say is our Zoom attendees. So you guys definitely get that chat box open. Say hi to me in the chat. Engage with me in the chat. I will try to keep an eye on the Q&A as well, but sometimes it gets a little bit more challenging because you have to individually click on it from my end. So get that chat box open and introduce yourselves. But I'm seeing a lot of familiar names and faces. So hi, Anna. Hi, Ruth. Hi, Ruthie. And Tiffany, which is really, really nice. Hi, Gloria from Nigeria. I'm also seeing a lot of familiar names and faces as we're streaming on our YouTube and Facebook channels, as well as Instagram and TikTok. So that's really exciting to me because you guys are the reason why we do this, right? So for me, as the director of advanced practice here at Archer, I really want to know what is the information you guys are looking for, what's going to be relevant to you and your practice. So that's why I ask, where are you joining from? Where are you in your nursing journey? It really helps me understand who's our audience that's joining. And then I want you to also tell us what you want. So do you want more content? Do you want more test questions? Do you want more case studies? And we really are changing the structure of our webinars pretty regularly to adapt to the students' needs. So your needs, right? And for those who have attended previous webinars in the past, know that we really do mean that, right? So these webinars have taken different shape over the last few years based on our audience. So today we're going to try our 30-minute webinar series where I'm going to talk to you about thyroid dysfunction. One thing that we're really thinking about is breaking up these webinars into two parts. So the first part is our 30-minute session where we just talk about pathophysiology. And then the second part is an hour-long session where we really get into the meat of the management. So that's something I want to throw out there for you guys today. As we're going through the webinar, I want you to think about where you think it would be the most use of your time in these webinars. So hi, Ruthie, FNP graduate. I also want to say for those of you who are NCLEX, I know we are streaming on our nursing platforms. We consolidated our social media onto one. So previously we used to have social media for just advanced practice, social media just for our RN and pre-nursing colleagues. But now we have consolidated. So you are more than welcome to join. I love the interaction. I think it's relevant to everyone. However, know that when we're going through this content, we're talking about advanced practice. So we're going to elevate what our foundation as nurses and really get into the meat of how do we assess, diagnose, and treat these patients with these thyroid dysfunction. So it's going to challenge you a little bit if you are getting ready for your NCLEX. So don't panic, but just let it wash over you, and you are more than welcome to stay. Before we jump in, I wanted to make sure we talked a little bit about what we're building out here at Archer. Again, we want your feedback on all of this. So when I'm presenting this, I want you guys to think about, well, is that something I need? Or what about this? Should you guys build this out? I know a lot of the students who join, so Anna sends me emails regularly. I have a couple other students that send me emails just brainstorming ideas of like, hey, if you guys offered this, that would be really relevant to me and my colleagues. I love those emails. Please send me those emails because that really helps me figure out what's going to be useful to you out there as you're getting ready to prepare for this important work of taking care of our patients, right? So welcome, welcome. I'm seeing some more people join now that we're at the top of the hour. We're going to get into the meat of everything. And before we jump in, for those who just joined, my name is Hiva Kolodrubetz. I'm a family nurse practitioner and with over a decade of experience as an NP in both primary care and specialty medicine, including endocrinology and cardiology. Those are my two loves. All right, you guys, we do have a live review coming up. So for those FNP students or adult gerio primary care who are getting ready for your board certification, join us on a live review. Morgan Boosie and I do these live reviews together. We built it out together and we built it with you in mind. We adapt it between each live review. We do them monthly and we really take the feedback and continue to build the content. So definitely join a live review. She and I were talking yesterday about who should we recommend this live review for, whether it's beginning stages of studying, whether you're in your program, getting ready for your clinical rotation. And we really realized that this live review is relevant to all nurse practitioner students anywhere in your journey, because what we're doing is showing you the breadth of the knowledge that you need to have to be really confident in going into clinical practice. So it's not so much focused on these are the questions that are going to be on the boards. This is what you need to memorize. We are moved away from recall questions, and it's really about critical thinking. And that's what Morgan and I focus on when we're teaching this live review. So really, we think it's a nice way, even for students who are considering a specialty or considering becoming nurse practitioners, it's nice to see what you're going to be responsible for when you're caring for your patients. And I've also had students joining before they join their or start their clinical rotations because, again, they have a good baseline of these are the things I'm going to see in primary care. These are the things I need to focus my clinical rotations on, as well as my studying for classes and for our boards exams. So I highly encourage you to check out our live reviews. Like I said, we do have one coming up every month. I think this month it happens to be on Earth Day, which is a lot of fun. And I'd love to see you guys there. If you have any questions, you're like, I just don't know where to even begin or focus my studying, definitely go ahead and email me and I'll be able to guide you in the right direction. But we have a lot of great things in our SurePass, which includes the live review, including our on-demand videos and our question bank. So, and including our free exit exams that we just built out in the fall. So definitely make sure that you're taking advantage of all of these wonderful products that are available to you. All right, so let's jump in. How many of you have seen patients with thyroid dysfunction? Go ahead and say yes, no in the chat. How many of you dealt with thyroid dysfunction yourselves? Maybe. Raise your hand. Maybe. Ruthie says yes. Yeah. So thyroid dysfunction. Why are we talking about thyroid dysfunction? This is something that we're definitely going to be treating in that primary care world. Remember, when it's pretty straightforward, you are going to be managing it in that primary care world, right? We're not going to be referring to endocrinology, because that referral takes so long. And we don't really refer to endocrinology unless we think there's something else going on that's outside of our scope, right? We need a second opinion. This patient is needing a higher level of care, right? So when we talk about thyroid dysfunction, this is definitely within our wheelhouse. And we'll talk about hypothyroid, meaning an underproducing thyroid. I don't want to say thyroid gland because we'll talk about primary versus secondary hypothyroidism, but we will be treating a lot of patients with hypothyroidism in primary care and also hyperthyroidism. A lot of students say, hey, I'm not going to be treating hyperthyroid. I'm not going into endocrine. You may be the first person to identify it. Assessment is big, diagnosis is big, and you're going to be treating it until they can get in to see endocrinology. Remember that wait period is a long time. We're going to be managing these patients until they can get into endocrinology. So when we're talking about the thyroid gland, we're talking about a gland that really produces a very important hormone. These thyroid hormones are T4 and T3. Put in the chat for me, what does the T4 and T3 do? What is it responsible for? What is this hormone? What are these hormones responsible for? Put it in the chat for me. And when we have a patient with hypothyroidism, meaning that they don't have enough T4 and T3 in their bloodstream when we're checking their labs, there are different reasons for why that could be. We have primary hypothyroidism, meaning the issue is from the thyroid gland itself. So remember, the thyroid gland sits at the base of the neck. So when you're doing your physical exam, I want you to practice feeling that thyroid on all your patients. I will never forget, this was maybe like a year ago. I was doing a new patient evaluation on a patient. And of course, they fill out that big, thick packet depending on your clinical site and what you decide to implement as a provider. And so we all have these new patient forms that the patients all fill out. And I'm going through it with the patient, and they're sitting there middle of the winter. So, they're kind of bundled up. And everything's a no, 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 no relevant medical history. So then I ask them to, get some layers off. I'm going to do skin to skin my physical assessment on them, right? So I start to assess them, and immediately I notice a huge goiter. And patient didn't mention anything of it, all no's, review systems, all negative. And sure enough, this was a pretty obvious goiter, but patients will omit things from their history. So you have to get really good at your physical exam as well, right? So take advantage of making sure you identify where that thyroid gland is, what a normal thyroid feels like, right? You should have a patient swallow so you can feel that thyroid gland go up and down. And you're feeling for nodules, you're feeling for any asymmetry, you're really feeling for anything that you'd want to further investigate with that physical assessment. So that thyroid gland, if there's something going on with the thyroid gland, that is a primary issue, right? So that would be primary hypothyroidism. Most common primary hypothyroidism we see is Hashimoto's thyroiditis. That's our autoimmune in the Western world. When we're looking outside of the Western world, iodine deficiency is the most common. So depending on your setting and where you'll be practicing, if you do global health, you might actually be treating patients with iodine deficiency, leading to primary hypothyroidism. And then, of course, there are other issues with patients who maybe have had an overactive thyroid nodules that they've had to have removed, if they've had surgery or radiation or radioiodine ablation. Then they will now be treated as primary hypothyroid patients, and they will need that synthetic T4 for the rest of their life because they may have a partial thyroid or no thyroid at all that we need to then be giving them that synthetic thyroid hormone. So what do you guys think? Every function in the body and metabolism, says Anna, is what the thyroid gland is responsible for. I love that. Yes, every function in the body. Absolutely. The thyroid gland really does impact a lot of things. That's why when we're looking at signs and symptoms, they're so vague, right? It really is a lot of different body systems. We might have some patients coming in with just signs and symptoms of fatigue. Some patients may be complaining of weight gain. Some patients may be complaining of cardiac issues, right? We always want to be thinking, okay, could this be an underlying thyroid dysfunction? Of course, we want to make sure we're adequately triaging that patient when we're looking at cardiac conditions, but we don't want to miss those secondary causes, right? So could this be an underlying thyroid issue? Patients coming in with chronic constipation. So I'm talking about really severe constipation. Usually we see this in our younger kiddos, right? We see growth issues, so they're not meeting their growth curve. And we're also seeing chronic constipation, maybe some pallor on the skin. And we're also seeing some muscle and joint issues with these kiddos as well. So it really does impact, as Anna said, all of these different body systems, right? Really important for growth in our younger kiddos as well. And then mood disorders, always, always, always make sure when you have a patient that you are treating for anxiety and depression, we are also ruling out any thyroid dysfunction. I have patients where that's the only sign and symptom that they present with is anxiety, depression. When we treat their thyroid dysfunction, they feel a lot better and they can go off some of that medication, that treatment, right? So it's really important to be thinking about the why behind everything when you're assessing your patients. Look at the patient holistically. So now getting into secondary causes of hypothyroidism. Remember that negative feedback loop. Who can tell me about that negative feedback loop? Hello, Manny from South Africa. Very cool. I've never been, but my husband has, and I'm so jealous. I want to go to South Africa. Welcome, welcome. A lot of great hiking, he said. So what are some potential reasons for what did I ask you guys? We're talking about secondary hypothyroidism. I lost my train of thought. Okay, so secondary hypothyroidism, that negative feedback loop. Yes. Okay, so your thyroid gland needs to get stimulated or not stimulated, right? Something has to give it a signal of, hey, we need more thyroid hormone, or hey, we have a little too much thyroid hormone out there. Let's pull back, right? That's what our TSH is. That's our thyroid stimulating hormone. And that is really being cascade is starting really in our pituitary gland. So when we're talking about hypothyroidism, sometimes the thyroid itself is functioning well, but the messaging, that cascade, that feedback loop is out of whack. And it could be due to something going on in that pituitary gland. So anytime it's within the thyroid gland itself, that's primary hypothyroidism. Anytime it's outside of the thyroid gland, that's going to be secondary hypothyroidism. And typically it's usually due to a tumor. So when we're trying to diagnose patients and figure out, okay, what type of hypothyroidism does my patient have? When do I treat? When do I not treat? We're really going to be doing some blood work. What's some typical blood work we might order, you guys? Put it in the chat for me. What's some typical blood work we might get on our patients? What do we think? TSH. Oh, Shaquana, great to see you again. I saw your feedback on the Q Bank. I really appreciate your feedback. I love to see feedback. Keep it up. All right, Anna says free T3, T3 and T4, Ruthie says. Very good, you guys. Yes, we call this a thyroid panel, right? And so the thyroid panel includes that TSH, that thyroid stimulating hormone, as well as T3 and T4. Those are our thyroid hormones. And we can really look at that thyroid panel to see, does this patient have overt hypothyroidism, or are they subclinical and there's somebody we're going to watch, or are we suspecting an autoimmune condition? Right? So the why behind it, right? So we have a patient coming in with signs and symptoms. We're suspecting a thyroid dysfunction. And so we're ordering that thyroid panel. And then based on that thyroid panel, we're going to make that clinical decision. Tell me, what is overt hypothyroidism? What does our TSH really need to be over for us to be thinking this is overt hypothyroidism? What are those numbers we're looking for, you guys? Very good, Karina. Very good, Danielle. Absolutely. All right, my friends, you guys are quiet on Instagram and TikTok. What do you guys think? What do you guys think? What do you guys think? Okay, so good guess, Anna. So with overt hypothyroidism, we're really looking for elevated TSH. So anything over really 8 or 10, right? Because that's when we really see those dips in those thyroid hormones, right? We see the T4 and the T3 are low. Subclinical is right around that 4 or 5 in that TSH. And the reason for that is because the body's still compensating, right? So our TSH is a little bit elevated. There's a little extra stimulation in the bloodstream that we're picking up on. However, our thyroid hormones are still normal. That thyroid gland is still producing. It's still doing the work and saying, hey, I'm getting a little bit extra signal. We need some more thyroid hormone. So we call that subclinical. And typically those patients may be asymptomatic. But you might have patients where you're suspecting, okay, this could be Hashimoto's, and we want to really keep a close eye on this patient who's in that subclinical range, right? When would you be ordering some antibodies? What do you guys think? This kind of goes a little bit more advanced, but when are we really thinking about ordering some antibodies? What do you guys think? Elevate TSH, very good, Sherry. Family history, genetics, very good, Shaquana. Absolutely. So if we're really thinking, okay, this could be Hashimoto's, then we're thinking along with that thyroid panel, we're also going to order that TPO, that anti-thyroid peroxidase antibody. And if that is positive, we can put that in the patient's chart. Do we need to keep checking that PTO? Anna says you get it at baseline to make sure that you're ruling out autoimmune. Okay. So I think that's where the nuances come into clinical practice, right? You could, some providers absolutely will also order that TPO when they're doing that thyroid pan, especially if you're in endocrinology and patients are coming to us because their primary care really can't get their thyroid hormones under control. We're going to think, okay, is this an underlying autoimmune condition? What's going on? Or if they have the personal or family history of autoimmune conditions, right? If I have a patient who has type 1 diabetes or some GI autoimmune conditions and they're coming in with signs and symptoms, I'm going to be thinking, okay, this could be more potentially an autoimmune. Let's get that antibody and see if it's positive. Once it's positive, you do not need to keep checking for those antibodies, right? You can just put it in the patient's chart. That's not going to change. And you can say, antibody positive, hypothyroid, primary hypothyroidism, which is also known as Hashimoto's thyroiditis, and you're treating that patient if they're in that overt category when we're diagnosing them. If they're in that subclinical, again, this is where the nuances of clinical practice come in. I know so some endocrinologists that do treat, especially our pediatric kiddos in that subclinical range, if they are positive with those antibodies, but that is taking it beyond entry level. Remember, when you are graduating, you are at entry level knowledge as a provider. You're going to be continuing to learn as a provider especially those first 2 to 5 years in clinical practice. So treatment, we've talked a lot about not having enough thyroid hormone, that T4 and T3. That's what levothyroxine is, right? So this is the generic name. Synthroid is the brand name. Levothyroxine is synthetic T4. So we are giving our patients thyroid hormone. That dosing is age and weight dependent. However, I want to caveat this because I see this sometimes in clinic. When you're calculating this initial dose, you always want to start low and go slow. You never want to start somebody on the dose that you think that they would eventually need to be on to sustain a euthyroid levels, because that patient could then become hyperthyroid, which does cause cardiac issues and a lot of other things, which we'll talk about when we get to hyperthyroid, but that hyperadrenergic state. So we definitely want to make sure we're starting low and going slow and adjusting that medication as we go. We're going to recheck those labs every 4 to 8 weeks and make adjustments based on the lab values that we see. Does that make sense, you guys? Ideal weight versus actual weight. I love that, Anna. Absolutely. So why are we giving levothyroxine T4 on an empty stomach? You guys have probably heard that. My students always know that that is the right answer. I want to know, I want you to challenge yourself and know the why. Why are we avoiding iron, calcium, antacids, PPIs? What do those all have in common? Why are we giving this on an empty stomach? Why do we give synthetic T4 on an empty stomach? Shaquana says best absorption. Very good. Absorption. Yes, Anna. Absolutely. Chelation, I think you mean the binding. Yes, the binding. So we're avoiding, look at these categories, right? Iron, calcium, antacids, PPIs. What do all these do? They can bind and reduce the acidity in the stomach. So the stomach needs to be highly acidic for us to optimize that T4. So we tell patients you need to take this on an empty stomach. Now, what do you do in our kiddos who can't take it on an empty stomach in the morning because they wake up, they're rushing to go to school, they have to eat breakfast, but they also need to be taking their thyroid medication. What are some solutions for that? What do you guys think? For maximum absorption. Very good, Sherry. Absolutely. What do you guys think? What are some solutions? And I recently talked to a grown adult about this because it's not just our kiddos. Think about the other end of the spectrum, our older female population who are taking biphosphonates that also need to be taken on an empty stomach. We have patients as they're getting older with multiple medications that they have to take on an empty stomach. I remember my grandmother joking that all day she's just sitting with an empty stomach pacing it out, all her medications that she had to take on an empty stomach. And she was a retired nurse. And so it's tough. It's a burden on patients. But yeah, Anna says when it's an empty stomach. I love that. Yeah. So sit at home all day. No, you said bedtime. I'm teasing. So absolutely. So I tell my patients, listen, thyroid hormone just needs that acidic environment. That's why it needs an empty stomach. Whereas our biphosphonates not only need the empty stomach, but we need to have patients sitting upright for at least 30 to 60 minutes with a full glass of water when they take it, because we really want those muscles in the esophagus to push it down so that we're not getting inflammation and esophageal burning. We don't want esophagitis, right? So when we have patients who can take a medication on an empty stomach, but they don't need to sit upright after they take it, they can take that at bedtime, as long as we've spaced it out between the last time they've eaten, at least 3 to 4 hours after a snack or dinner. And that's usually a really good time for our kiddos to take it too, and our older patients that are on other medications, or our teens that may be on doxycycline for acne. So it really does impact a lot of our patients, and knowing the why, that's where the patient education comes in, right? So that might be an evaluation question. You have a patient where you just can't get their thyroid levels at optimal level. And the reason for that is because they're taking it not on an empty stomach. Well, why is that? Well, I don't have the time. You need to dig. You need to dig with your patients if we're not getting to goal. Why? What's holding us back, right? And so you need to know the why behind it. Why do we take it on an empty stomach? That's what we need to study when we're studying these things, not just memorizing. The last thing I'll say about synthetic T4, levothyroxine is the generic, usually works in most patients. However, in some patients where they may be a little bit labile, they might be a little bit more sensitive to the T4, we do switch them over to brand. It seems to help stabilize their thyroid levels a little bit more. And the reason for that is because it's similar to generic, any kind of generic medication versus brand medication. It's a little bit more, what's a PC word for it? Not regulated, but you have the same amount of medication, you have the same amount of T4 in that one pill from pill to pill, as opposed to with generic, there may be some slight differences in the amount of T4 and fillers that are in that. The brand Synthroid is expensive, so you have to work with your patients on that. So be mindful of that and see what your resources are in clinic. Last thing I'll say, I know I keep saying last thing, I can talk about this forever. With our pregnant moms, they may have a higher dose requirement, and these are definitely patients that need to also be co-managed by endocrinology during their pregnancy. Why is that? Can you guys tell me in the chat? Why do our pregnant moms require a higher dose of their synthetic T4? What do you guys think? Mo, Livnos, Peace, Ruthie, Ruth, Tiffany, Shaquana, Anna, Ashley, Jeanette, Jennifer, what do you guys think? That's a good guess, Anna. Anna says increased metabolism. Do you guys agree with that? Due to baby. Okay, that's a good guess. They tend to have more hormone production. Okay, these are all really good guesses. So you guys, I'm presuming you're all family nurse practitioners, so this is within your wheelhouse. The fetus does not produce its own thyroid hormones until towards the end of that first trimester. So if we have a mom who has primary hypothyroidism, she needs to not only produce enough T4 and T3 for her body, but also for the fetus and for the growth and development of the fetus. So we're going to have a higher dose, right? And so we're going to be watching these moms a lot more closely. Typically, we'll adjust their medication every 4 weeks. We'll check every 4 weeks. And some clinicians will bump up their T4 in anticipation of that first trimester. So definitely something you want to co-manage with endocrinology specialists. Okay, so I see that we're at the half hour, and this is why we were thinking about switching over the webinar structure a little bit, but we'll talk about that in a minute. I want to finish the content first for you guys today. So hyperthyroidism, this is that overproduction of the thyroid hormones T4 and T3, and typically we'll see lower levels of TSH. Why? Thyroid stimulating hormone. The body is detecting that feedback loop is saying, whoa, we have a lot of thyroid hormone out there. Our T3 and T4 levels are really elevated. No more stimulating that thyroid gland. Hold up. So you're going to see low levels of TSH. We call those suppressed levels. And again, you have two different types. You've got primary versus secondary hyperthyroidism. And primary is when there's an issue with the thyroid gland itself. It's going rogue. It's just producing a lot of thyroid hormone. Secondary is when the issue is within the pituitary gland. And that's when the pituitary gland is signaling, hey, we need more thyroid hormone. And so the thyroid gland is just overproducing. And so sometimes with that secondary hyperthyroid, you may see normal levels or even elevated levels of TSH. But again, that's beyond entry level knowledge. Just know, typical hyperthyroid patient, you're going to see that hyperandrogenetic state. You're going to see overproduction of T4 and T3, and you're going to see low levels of TSH. The most common cause of that primary hyperthyroidism is autoimmune. We see Graves' disease, that's our autoimmune primary hyperthyroidism, but there are also other causes like nodules, multinodular goiters, solitary nodules. Thyroiditis is transient, so sometimes we might see some transient thyroiditis that causes those elevated T4, T3 levels, which then does go away. Metastatic as well, but typically we're going to see that in a patient with that autoimmune Graves' disease. Now, what are those signs and symptoms? A little bit on the reverse, right? When we're looking at hypothyroidism, so signs and symptoms of hyper, we're going to see someone who's more anxious, more irritable. Maybe they have that heat intolerance because their body is just already in that hyperandrogenetic state. Tachycardia, they might have some weight loss, frequent loose stools, right? A lot of stimulation in the GI tract. They're frequently losing weight, having loose stools, but they also may be fatigued. Their body's in overdrive, right? So that fatigue, absolutely. With Graves' disease, telltale signs and symptoms are the exophthalmos, which is the protrusion of the eyes. Again, read about the why, right? Why does hyperthyroidism cause that inflammation in the vasculature behind the eyes, causing exophthalmos as a sign and symptom? And when we're managing these patients, not only are we getting them over to endocrinology, but we're also getting them over to ophthalmology, right? And we want to be asking questions about, are they sleeping? Can they close their eyelids? Have them close their eyelids for you in clinic, making sure we're not drying out those eyes because of that increased inflammation. Labs are going to be the same. We're going to look at that thyroid panel, TSH, T4, T3 to figure out what we're, to confirm or rule in or rule out our diagnosis. And then if you want to get really fancy, you can also order those antibodies if you're suspecting Graves' disease. But for everything else, we're going to wait for endocrinology, right? Endocrinology is going to do a more in-depth workup to figure out, okay, let's do a sonogram to look, is this caused by multiple nodules? Is this a solitary nodule? What's going on with this patient's thyroid? They're also going to do some other testing to rule in or rule out treatment options. But in the primary care world, we're going to manage these patients so that they can safely be waiting to see endocrinology, but honestly also picking up the phone and saying, this is my patient, how quickly can you get them in, is a great idea. Beta blockers are our first line for the palpitations, that anxiety, that irritation. Beta blockers are really helpful. Some patients really don't like them because how they feel on them is not great. If they can't tolerate beta blockers, we're going to try calcium channel blockers. That's our appropriate alternative. And then we may also be starting them on those anti-thyroid medications. So knowing those contraindications, when you would give what. There's a lot of controversy behind when you would give methimazole and PTU in pregnancy and not in pregnancy, depending on the trimester. Remember, those are really not entry level, right? You just have to really be looking at the global picture of how are we managing these patients? What are those next steps? How are we reevaluating that these patients are tolerating the treatment as they get in to see our specialist partners? And then they will talk to them about the definitive treatment, whether they want to have a thyroidectomy, they need to go to a different surgeon for that. If they want to continue with those anti-thyroid medications, pursue radioactive iodine therapy, read about these different treatment options because it's interesting to know about, because then you'll know how you need to manage those patients moving beyond what happens after radioactive iodine therapy and thyroidectomy. You need to be treating them for hypothyroidism. They might have some parathyroid issues as well. So reading about those treatment options is good for you to know, but knowing that most likely we're going to be getting them on those beta blockers and those anti-thyroid medications and referring them out to endocrinology and ophthalmology to make sure that they're getting the treatment that they need. All right, you guys, we're at the top of the hour. Let's skip past this one because I think you guys all know this one. And we all know this one too. I think you guys are doing great with knowing what to order. And this is an image of exophthalmos. Okay, being respectful of your time, I want to make sure that I didn't go too far over. I want to hear from you guys. What did you like about this webinar? What would you have liked to see more of? What would you like to see less of? So we didn't really get into dissecting clinical vignettes and going through practice questions. Is that something that you care about? Do you guys want to see those practice questions, or do you want the content? The other thing that I mentioned earlier in the webinar, for those of you who joined on time, I started a little bit early just to get to know you guys. I mentioned that we're thinking about restructuring the webinars to take one topic like thyroid dysfunction and break it up into part 1 and part 2 webinars. So the first part would be a 30-minute webinar where we go through the pathophysiology. And then the second part would be an hour-long webinar where we go through the management. So that's kind of something Morgan, Boosie, and I have been brainstorming. What do you guys think? I want to hear from you guys. Do you want more content? Do you want longer lectures, shorter lectures? Do you just want rapid fire test questions? What do you guys like? What is going to be useful to you? Anna says, love the idea of a 30-minute followed by the hour long. And it would be broken up into 2 different days, to be clear about that. I like it broken up into parts, says Ashley. I like the content and question session, says Peace. Shaklara says, me too. Okay, so it sounds like your guys are liking both content and making sure we have some time for questions. So maybe breaking it up into 2 where we focus on pathophysiology in 30 minutes and we have some questions related to pathophysiology, and then management, and we have some questions related to management. Is that a fair assessment of the feedback? Both content, Q&A, says Jennifer. I prefer if it wasn't rushed, says Peace. Yeah. Ruthie, content and questions. Ashley, Jennifer, everyone's agreeing. Okay, so 50-50 content and questions. Awesome. All right, well, if that's the case, Morgan, Boosie, and I are going to work on the calendar a little bit and add some webinars, and we're going to break some webinars up. So be mindful of keeping an eye on what webinars are coming up, and you'll see some new ones added in there too. Matt, who is in our marketing department, and he's wonderful. He usually sends out emails to those who already have a student account with Archer. So make sure you're signing up for a student account, even if it's just a free account right now, because you're enjoying the webinars, you're not looking at any products yet. Because on those free student accounts, you can try the demo, you can use the exit exams for free, but it also gives you those email alerts when we add things, when we add content for free, like the webinars. And it also gives you just like email alerts about any new content or any live reviews or anything like that coming up. So make sure you have added yourself to the student account so that you can see everything that's coming up. Otherwise, definitely make sure you're so welcome, Ruthie. I'm so glad that you enjoyed today's webinar. Please make sure you reach out to me with any questions. Check out our board power prep is what we call that one-day live review. We have one coming up this month. Check out our SurePass, which includes that. It's a really great deal. It includes that. It includes our exit exams. It includes the on-demand videos, our Q bank, all that great stuff. Morgan and I are actually working on adding more questions to the Q Bank, and we're continually updating them. So our Q Bank, if you guys like it, don't like it, send that little feedback button. So I really appreciate that when I see you guys sending that feedback. And that's it. Enjoy the rest of your day, you guys. And I appreciate your time, and have a wonderful rest of your Wednesday.